Welcome to the deep dive. Today, we're getting into infrainguinal vascular disease, basically, blood vessel problems below the groin.
Yep. And specifically, how endovascular therapy, those minimally invasive treatments, fit into managing peripheral arterial disease overall.
Exactly. We've got some great sources chapters from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition.
Solid stuff.
So our mission today is really to get a clear picture of these endovascular options based on what Rutherford's tells us.
Think of it as a walkthrough. What treatments are out there when leg arteries get blocked? When should you use them? What's the evidence say? That kind of thing.
Okay, let's dig in. First off, it's really important to say endovascular therapy, it's usually not step one for everyone.
Not at all. The sources really hammer this home. Medical management is the foundation.
Yeah.
Lifestyle changes, meds.
Right, things like quitting smoking, getting blood sugar under control if you have diabetes, taking statins, anti-platelets.
And those supervised walking programs, too. Critically important.
Endovascular stuff should really complement these, at least initially. It doesn't replace them.
Absolutely.
Hmm.
Those basics slow the disease down, manage the risks. It's interesting, though, when you look at specifics. That's smoking.
Yeah.
We know it's terrible for PAD. Really ups the risk of bypass grafts failing.
Yeah.
But surprisingly, the data isn't quite as clear-cut, showing that same jump in risk for bad limb outcomes after endovascular work in active smokers.
Huh. That is interesting. What about statins? Cholesterol drugs, they seem key.
Oh, they absolutely are. Especially high-intensity statins. They've been shown to cut down major adverse limb events, even reduce mortality in PAD patients.
Oh.
And when you combine statins with actually doing a revascularization procedure, the outcomes look better. Better patency, keeping the vessel open, better limb salvage, better survival. It's really about the whole approach.
So not just the procedure in isolation, it's the whole package. Okay. ACE inhibitors. Often hear about those for heart issues. Do they play a role here?
Good question. Yes, the evidence backs them up for reducing cardiovascular death in PAD patients, too.
Right.
And what's really relevant for our chat today is that for folks getting endovascular treatments, ACE inhibitors seem linked to better overall survival and amputation-free survival.
Got it. So manage the underlying stuff first, then intervention. Now, anti-platelets, aspirin, clopidogrel, pretty standard for PAD, aren't they?
They are standard, yeah,
Hmm.
especially for symptomatic PAD people actually having leg pain, claudication. Antiplatelets are crucial for cutting cardiovascular risk.
Even though some big analyses didn't show a huge difference across all PAD patients.
Right. Despite that finding in one meta-analysis, the guidelines are still very strong Class 1A recommendation for antiplatelets if you have symptoms.
Okay.
And some of the newer drugs, like ticagrelor, haven't really panned out as being better than clopidogrel for PAD specifically.
Good to know. So symptoms mean antiplatelets are a definite. What about anticoagulation, like blood thinners? That's a different ballgame.
Yeah, a bit different. There's been, renewed interest lately because of a big trial called COMPASS.
Oh,
It found that adding low-dose rivaroxaban, that's a blood thinner, to aspirin actually led to lower rates of cardiovascular events and major limb problems, including amputation, compared to just aspirin.
and that was in patients with cardiovascular disease generally?
Exactly. But importantly, there was a big subgroup in COMPASS that had PAD. So that really got people thinking.
Which led to another trial.
Yep, Voyager. Specifically looking at PAD patients after they've had a revascularization procedure. We'll circle back to Voyager later. It's pretty important.
Okay, sounds good. So medical management first, then endo options if needed. Left pivot to intermittent claudication. I see that leg pain when walking.
Right. And again, for IC, medical management is really the main therapy. The progression rate to needing an amputation is actually pretty low for most people with just claudication.
So when does endovascular therapy even come into play for IC?
It's really an option for those folks whose lives are seriously impacted by the pain, despite trying the best medical therapy, including supervised walking. But, and this is a key but, the long-term data on how durable these endovascular treatments are, like angioplasty, stents, atherectomy for just IC, it's not as strong as the data for supervised walking itself.
And we need to be careful about studies too. Maybe some bias.
Yeah, you have to look closely. Sometimes industry-sponsored trials might have shorter follow-up, or they lump together patients with IC and those with the much more severe CLTI, critical limb-threatening ischemia. It makes comparisons tricky. Apples and oranges, kind of?
That makes sense. And you mentioned something about target vessel revascularization, or TVR, that measuring success just by whether the vessel stays open might not tell the whole story for IC patients?
Exactly. TVR just looks at the plumbing, basically. Did the treated artery stay open? But that doesn't automatically mean the patient is walking further or feels better.
Right.
There was a meta-analysis, the Wilson analysis, that really drove this home. It found endovascular therapy might improve the ABI, that blood flow measurement.
Ankle brachial index?
Right. But the medical management group actually reported better walking distances in the longer run. So just keeping the artery open isn't always the main goal for the patient's quality of life.
Good point. Patient-centered outcomes matter. Okay, let's get specific. Femora popliteal segment, the thigh artery, down to behind the knee. Sources say this is the most common spot for IC problems.
That's right. The SFA, superficial femoral artery, running down the thigh. Now, if the blockage is right up high in the common femoral artery...
In the groin area.
Yeah. Open surgery and endarterectomy. Basically cleaning it out with a patch, that's often still preferred there.
Okay.
But for narrowings or blockages lower down, in the SFA itself, maybe extending into the popliteal artery behind the knee. Especially shorter ones, say less than 4 centimeters. Endovascular is often the first thing considered.
And there are lots of tools for that.
Oh, yeah. Plain balloon angioplasty and atherectomy, bare metal stents, covered stents, drug-coated balloons, drug-eluting stents, the whole toolkit. But it's a tricky area, mechanically speaking. Lots of bending, twisting, potential for compression.
Right, the leg moves a lot. Let's break down those tools. Plain old balloon angioplasty PDA. That was the original, yeah?
It was. Just inflate a balloon, push the plaque aside, open the vessel. Simple concept.
But it has limitations.
Definitely. Sometimes the balloon pressure tears the artery wall into dissection. The artery can also shrink back down over time, negative remodeling. And restenosis, the artery narrowing, again, is a big issue.
So it doesn't always last?
Not always, no. Trials like BioAUX PI, the Antrobad SFA, they showed PBA often doesn't hold up long-term. Higher rates of needing another procedure, higher TVR.
So when is PBA maybe useful?
Maybe for really short blockages. And really only if the patient is super committed to follow-up and sticking with all the medical management stuff. Otherwise, the re-narrowing rate is just too high.
Okay. What about balloon expandable stents, the rigid metal ones?
They were used initially sometimes as a bailout if PBA caused a bad tear. But generally, they're not used much in the FemPop segment anymore. Some studies actually showed they might do worse long-term than PBA alone in this area.
Okay. So self-expanding stents, those sound more common now, made of nitinol.
Absolutely. Nitinol is that flexible metal alloy. These stents are designed to handle the movement in the leg better, resist crushing.
And the evidence supports them.
Yeah, pretty well for IC. The Resilient trial, for instance, showed stenting beat angioplasty alone for needing fewer reinterventions.
Fewer TVR.
Right. And other trials like Durability 2, Complete SE, they reported good 1-year patency, especially in lesions that weren't super long and patients felt significantly better. Their Rutherford class improved.
Any longer-term data?
Yeah, there's data on some specific types, like helical woven nitinol stents, think Supra, showing decent patency even at 6 years, low reintervention rates.
So they seem like a good option for those sort of mid-length to longer blockages, say over 4 centimeters?
Generally, yes. For claudicants who failed medical therapy, if the lesion is more than just a very short focal spot, self-expanding nitinol stents are often the first-line endovascular choice.
What about really long lesions, like over 15 centimeters?
Even then, self-expanding stents seem to do better than just angioplasty, though the overall patency rates are definitely lower for those super long ones. Durability 200 looked at really long stents, like 200 millimeters.
Yeah.
Patency was okay at a year, but they did see more stent fractures.
And covered stents, stents with a fabric layer.
They've been looked at especially for long lesions. The Vibrant trial compared them to bare metal stents, found similar initial patency, but maybe worse long-term assisted patency. And there's a worry they might block off important side branches, collaterals.
Okay, so for those mid to long lesions and claudicants, self-expanding stents are a strong contender, but follow-up is key.
Absolutely key. And it's worth comparing, the 1-year patency you might get with a stent versus the 5-year patency from a bypass using the patient's own vein. If the targets for bypass aren't great or the vein quality is poor, maybe endo first makes sense, even with slightly lower long-term durability.
That's a really practical point. Okay, shifting gears slightly to the drug-coated stuff. Drug-eluting stents, DES, and drug-coated balloons, DCB. The goal here is preventing that re-narrowing the restenosis, right?
Exactly. Reduce inflammation, stop that smooth muscle cell overgrowth neointimal hyperplasia that causes the artery to narrow again. We saw this tech work well in heart arteries first.
How's it fared in the leg? There was a trial, Sirico.
Right, Sirico used a sirolimus eluting stent. It didn't actually show superiority over bare metal stents. Maybe because the bare metal stents in that trial just performed unusually well.
Zilver PTX, that used paclitaxel, a different drug, on the stent. That one seemed more positive.
It did, initially. Zilver PTX showed much better primary patency artery, staying open at both 1 year and even 5 years compared to just plain balloon angioplasty. Patients did better clinically, too.
And this is a big but we need to address. The whole paclitaxel safety issue.
Precisely. That Zilver PTX data looked good on patency. But then came the meta-analysis, raising serious concerns about increased mortality down the line with paclitaxel-coated devices. Huge deal.
We definitely need to unpack that controversy. Before we do, what about DCBs? Drug-coated balloons?
Yeah.
Also paclitaxel for the legs, right?
Yes, for peripheral use, it's paclitaxel on the balloons.
Mm-hmm.
And DCB trials, comparing them to PBA or PBA plus a bare metal stent, have pretty consistently shown lower rates of losing patency and needing repeat procedures, TVR, usually out to 12 or 24 months.
Okay.
You see that in trials like Thunder, Passfire, Impact, SFA.
And impact on amputation for IC patients?
Well, the amputation risk in IC is already super low, so DCBs don't seem to change that baseline low risk much, which makes sense.
Right. So DCBs help keep the artery open longer, less TVR and IC, but no big change in the already low amputation rate. Now let's tackle that paclitaxel controversy head on. It's clearly casting a shadow.
It absolutely is. That systematic review published a few years back suggesting higher all-cause death rates at 2 years with paclitaxel devices that send shockwaves.
Understandably.
And the follow-up has been, well, complicated. Post-market data is mixed. The Zilver PTX long-term follow-up didn't show a mortality difference at 5 years.
Yeah.
A big Medicare dataset analysis didn't either, but an FDA analysis did confirm an increased risk of death at 5 years. So the signals are conflicting. And crucially, the biological reason why this might be happening isn't understood. We don't know the mechanism.
Which makes conversations with patients critical.
Essential. You have to be upfront. Discuss the potential mortality risk versus the known patency benefits. It's a difficult balance. The SVS, Society for Vascular Surgery, even has a task force monitoring all the incoming data. It's a very active area of concern and research.
Really highlights the complexities. It's not just about better patency equals better outcome anymore. Okay, let's move down the leg. Behind the knee, the popliteal artery proper, stenting there, generally avoided.
Generally, yes. It's a high flexion zone, lots of mechanical stress. Stents there are more prone to fracture, which can lead to, you guessed it, restenosis or even sudden blockage.
So usually not recommended.
Not routinely, maybe, just maybe, in a very specific CLTI patient, someone really high risk for surgery, where it's a last-ditch effort for limb salvage. And maybe future stent tech will change things. But for now, tread very carefully with popliteal stenting.
Makes sense. How about even further down, infrapopliteal, the tibial arteries in the calf? What about treating isolated disease there just for claudication?
Generally not indicated. It's not even totally clear how much isolated tibial disease causes typical calf claudication.
Okay.
Plus, we just don't have good data on the utility or durability of intervening down there only for claudication relief. Most of the data we have for tibial interventions, angioplasty, stents, DCB, DES, comes from treating CLTI patients.
So very different patient group.
Totally different. There was one study showing tibial angioplasty was technically feasible and had okay patency at a year in moderate claudicants, but long-term benefit, unknown. And you have real risks. Dissections, clots, potentially messing up future bypass options.
So for just claudication in the tibials, the risk probably outweighs the uncertain benefit.
Got it. What about atherectomy? Physically removing plaque. Role in IC. Atherectomy, directional, rotational, laser. The idea is to debulk the plaque, carve it out, rather than just push it aside.
Does it work better?
Well, one known risk is distal embolization. Little bits of plaque breaking off and going downstream, blocking smaller vessels. Reported rates vary, maybe 1–2% overall, but could be up to 20% with some devices. You can use filters or aspiration catheters to try and catch that debris.
But does it improve outcomes for IC?
The data is not compelling for IC alone. Using atherectomy in the fempop or tibials for just claudication seems linked to high reintervention rates, maybe even higher amputation rates in some analyses.
Ooh.
Yeah. The definitive ELLI trial showed patency similar to newer nidinal stents, not clearly better, yet its use seems to be going up. There's a concern, frankly, that reimbursement might be driving some of that increase rather than solid evidence of benefit for IC.
That's concerning. Need to stick to evidence-based practice.
Okay, powerful discussion on IC. Let's switch now to chronic limb-threatening ischemia, CLTI, the really severe end. Here, the goal is saving the limb. right?
Absolutely, no question. With CLTI, rest pain, ulcers, gangrene intervention is necessary. The debate isn't whether to intervene, it's which strategy is best. Open surgery or endovascular.
And the basal trial was key here. Compared surgery first versus angioplasty first.
It was landmark, yes. It found basically no difference in amputation-free survival or overall death rates between the two strategies for the first 2 years.
But after 2 years,
After 2 years, the surgery group started to look a bit better in terms of survival free from amputation. But importantly, the surgery group also had more complications and higher costs in that first year.
so a trade-off, kind of. The basal authors suggested maybe angioplasty first is reasonable for patients with a shorter life expectancy, maybe only 1-2 years, to avoid the upfront surgical risks. It highlights balancing life expectancy with procedural risks, and newer guidelines now define high-risk surgical candidates more clearly.
We should remember basal used older tech though, right? Mostly just balloon angioplasty.
Crucial point. Endotech has evolved hugely since basal. Plus, about a quarter of the surgery patients in basal got prosthetic graft below the knee, which isn't ideal if good vein is available.
Which is why we need newer trials comparing current best practices.
Exactly, like the BEST CLI trial. That was designed to compare the best available endovascular therapy versus the best available surgical therapy, letting doctors choose the specific tools and targets. More real world.
And then the results.
Enrollment finished, follow-up is ongoing. We're eagerly awaiting those results. Plus, Basal 2 and Basal 3 are coming too, looking at other specific comparisons. So for now, the CLTI endo versus open decision. It often boils down to the patient's surgical risk and how bad their wounds are.
Okay. So for CLTI, in the femoropopliteal segment, keeping in mind these patients often have disease everywhere, what's the data on just treating the SFA?
It's a bit limited, actually. Most device trials focused on claudicants, remember. What we see from looking back at data retrospective studies suggests CLTI patients generally do worse after femoral interventions than claudicants do.
Makes sense, sicker patients.
Yeah, and complete blockages, occlusions, in the SFA seem to have lower patency after endo compared to just narrowing stenosis.
What about PBA versus bypass for SFA and CLTI?
Some limited short-term data suggests similar early patency and limb salvage, but the studies are small. A lot of the PBA data comes from the basal endo arm.
And PBA is harder in CLTI.
Often, yeah. Technical failure rates are higher. It can be tough to cross those really calcified long blockages or get back into the true artery channel.
And if PBA fails?
Well, Basal suggested maybe doing another intervention quickly after failed PBA might help early survival, but the long-term picture is unclear. What is clearer is that failed PBA, followed by a bypass, generally leads to worse overall outcomes than if bypass was done first.
That's critical. A failed endo attempt can burn bridges for surgery. Does adding a stent to PBA help in CLTI, like it does in IC?
It's unclear. Actually, one study in CLTI patients showed higher restenosis with stenting compared to PBA alone. Kind of the opposite of the IC data.
Wow.
It just shows the toolkit works differently depending on the patient and disease severity. And remember, CLTI often means multi-level disease, so you're likely intervening in multiple places anyway.
Right. What about DCDs in the SFA for CLTI? Do they offer an advantage?
There's some encouraging data. Debate SFA, mostly severe CLTI patients, found no amputations at 12 months in either the DCB plus stent group or the PBA plus stent group, but the DCB group had less restenosis.
Okay, lower restenosis is good.
Yeah. And Debellum, also mostly CLTI, showed lower TVR at 6 months with DCB, though amputation rates are similar. Maybe the study was too small to see a difference there.
So DCBs seem to reduce restenosis and TVR in CLTI fem-pop disease?
But maybe not consistently impact amputation or mortality, possibly because these patients are just generally sicker cardiovascularly.
So maybe DCBs are best for high surgical risk CLTI patients needing an endo approach.
That seems like a reasonable niche, yes.
Mm-hmm.
And that whole paclitaxel mortality concern. It might be less of a factor, relatively speaking, in CLTI patients because their overall life expectancy is often shorter anyway due to other health issues.
An important consideration.
Mm.
Okay, back down below the knee, infrapopliteal disease in CLTI. You said DES and ECB use has grown a lot here since Bagel.
Yeah, huge growth. The tibial arteries are small, kind of like coronary arteries, so the drug-based tech developed for the heart seemed like a natural fit to try and save limbs.
Plain balloon angioplasty is still an option.
Absolutely. PBA alone has held its own. Propensity-matched studies comparing it to bypass show similar 5-year survival, amputation-free survival, and limb salvage, even though the patency rates of the angioplasty itself are lower than bypass.
So PBA is definitely still in the mix.
For sure. especially for patients too sick for a complex distal bypass, or just to get enough flow to heal a distal wound. One study showed nearly 70% wound healing with PBA, though it can take a long time.
What about stenting the tibials in CLTI?
Mixed results. The EXPAND study showed similar outcomes between self-expanding nitinol stents and PBA in a mixed IC-CLTI group. A big Cochrane review found stents gave better early technical success and patency than PBA. But those differences vanished by 6 months. No difference in amputation or limb salvage. The studies were all quite different, making firm conclusions hard. So probably best to be cautious. Maybe stick mainly with PBA unless there's a specific reason for a stent, like a flow-limiting dissection.
Okay, drug-eluting stents then. DE in the tibials. Some early hype there.
There was some promising results initially, especially with sirolimus-eluting stents. Yukon BTK showed lower major amputation rates with DES versus bare metal stents. Paradise reported great 3-year outcomes with mostly everolimus-eluting stents.
But that hasn't held up consistently.
Unfortunately, no. Achilles showed better patency with DES, but no difference in amputation rates at a year. Destiny showed less need for repeat procedures, TLR, but again, no impact on amputation.
So maybe better patency doesn't always translate to saving more limbs in these very sick patients.
It seems that way. Improved patency might lead to better outcomes, but maybe the limited lifespan of many CLTI patients means they don't live long enough to see that benefit fully play out. Plus, the current DAS are mostly short coronary stents, not ideal for the long diffuse disease we often see in tibials.
Right, technical limitations too. And finally, drug-coated balloons below the knee for CLTI.
Okay, IMPACT Deep looked at paclitaxel DCBs versus PBA in mostly severe CLTI at 5 years. Amputation rates were similarly low in both groups. No difference in mortality either. Other trials, like Debate, showed some early patency benefits with DCBs, but again, amputation rates were often so low it was hard to compare. BIOLO UX Second Registry showed pretty similar outcomes for DCB versus PBA across the board at 1 year.
So maybe the aggressive care in these trials helps everyone?
Could be. Aggressive follow-up, good medical management. Maybe that lowers the expected amputation rates overall. So, the takeaway. DCB or PBA can both be part of an aggressive strategy for tibial CLTI. But again, tech limitations exist, like balloon sizes available.
It really sounds like below-the-knee CLTI treatment is complex, individualized, and still evolving. Let's touch on special considerations. Hybrid procedures, combining open and endo.
Exactly, using the strengths of both in one go, like doing an open cleanup of the femoral artery, then maybe stenting the iliac artery above it retrogradely, or vice versa.
Makes sense.
Or maybe stenting the SFA to get inflow down further, then doing a shorter bypass from there if vein is limited. Some studies show good results even with bypasses going all the way down to the foot pedal targets, after stenting proximally.
So it expands the options.
Definitely. And if a hybrid fails later, often due to outflow disease getting worse, sometimes another hybrid approach like cleaning out the graft clot and doing angioplasty downstream can fix it.
Clever. What about Safari? Sounds adventurous.
Yeah. Subintimal arterial flossing with antegrade retrograde intervention. It's for really tough blockages, maybe when standard options aren't great.
How does it work?
You get access both above the blockage, the usual way, and below it, typically by sticking an artery in the foot retrograde axis. Having wires coming from both directions makes it easier to navigate through that subintimal plane between the artery layers and then reliably pop back into the true artery channel downstream. You need some open artery above the ankle to get that foot access.
And the results?
Pretty decent for complex situations. Patency around 60% at 3-6 months maybe. Limb salvage reported around 80% at 5 months in some series, maybe even higher 1-year salvage in smaller studies. It's another valuable tool for limb salvage, especially for complex tibial disease.
Good to have more tools in the box. Okay, so we've done the procedure. What about afterwards? Medical management after endo seems just as vital.
Absolutely critical for long-term success. We already said anti-platelets are key for symptomatic PAD, and that definitely extends to post-endo patients.
Evidence supports that.
Well, some big trial analyses didn't show a huge extra benefit just in the endo subgroup for major cardiovascular events, but a Cochrane review did show aspirin improved patency at 6 months versus placebo after endo.
What about dual antiplatelets? DAPT, aspirin plus clopidogrel.
There's a mechanistic rationale reducing platelet activation around the procedure, and registry data shows DAP is used a lot after lower extremity endo.
But is it always needed? Or for how long?
That's the million-dollar question.
Hey.
Maybe it's best for specific situations like CLTI versus IC to balance the benefit against bleeding risk. still being figured out. An older review suggested LMWH might beat aspirin alone after endo for CLI, but that data's old. Right now, no strong evidence to routinely add or switch to long-term anticoagulation after endo instead of antiplatelets.
Which brings us back to Voyager Pad, looking specifically at adding low-dose rivaroxaban after revascularization.
Exactly. Building on Compass, Voyager took PAD patients within 10 days of any peripheral revascularization endo or open and randomized them to low-dose rivaroxaban plus aspirin versus aspirin alone. Clopidogrel was allowed for up to 6 months, too.
And the results were positive.
They were. The primary outcome, a mix of bad cardiovascular stuff and limb events like acute limb ischemia or major amputation, was significantly lower in the rivaroxaban group over 3 years. Fewer unplanned repeat revascularizations, too.
But the trade-off, bleeding.
Yep. More major bleeding by IST's criteria in the rivaroxaban group, though, importantly, fatal bleeding and brain bleeds were similar.
Did it matter what kind of procedure they had, or if they were also on clopidogrel?
Benefit seemed consistent across procedure types, and adding clopidogrel on top of rivaroxaban aspirin didn't add benefit, just increased bleeding more.
So Voyager suggests a potential benefit for adding low-dose rivaroxaban after revascularization, but requires careful patient selection due to bleeding risk.
Precisely. Careful selection is key. We need more research to know exactly who benefits most from this combo therapy.
Okay. One more medication, silistazole. Any role post-intervention?
Yeah, silistazole helps walking distance in IC patients, usually well tolerated. And a Cochrane review suggested it might also reduce restenosis and reocclusion rates after endovascular procedures.
So maybe worth considering.
Yeah, especially if the main reason for the intervention was limited walking distance in the first place. Starting silistazole afterwards could make sense for those patients.
Okay, treated, medically managed. Now how do we watch them? Surveillance after endo seems really important for catching problems early.
It is. All PA patients need regular follow-up anyway for disease progression, making sure they're taking meds. But after an endo procedure, routine checks with duplex ultrasound and those ABI measurements are key.
Why?
To spot instant restenosis or intervention failure before it becomes a major problem, maybe even before symptoms return.
Are there specific signs to look for on ultrasound?
Yes. Things like really high blood flow velocity inside the treated segment, over 300 centimeters, or paradoxically very low velocity, under 50 centimeters, or a big jump in velocity compared to the artery just before it, velocity ratio over 3. These can signal significant narrowing.
And the ABI.
A drop in the ABI of more than 0.1 is often the very first objective sign something's wrong, even if the patient feels okay. And if the ultrasound looks good, no high velocities. That's a strong sign things are likely staying open.
So a structured surveillance plan is needed.
Definitely. Something like checking it 1 week, then maybe every 3 months for the first year, then every 6 months. That kind of regular monitoring helps catch issues early when they might be easier to fix.
Right. Early detection, early treatment. Well, this has been a fantastic deep dive. We've covered a huge amount on endovascular therapy for infrainguinal disease, all based on these Rutherford's chapters. It's clear things have advanced so much, and it's still changing.
Absolutely. The field keeps evolving. Techniques get refined, research gives us more nuance, with this incredible range of tools now, which lets us tailor the approach much more to the individual patient, their specific blockages, the doctor's skills, what tech is available.
It's impressive. So considering all that complexity, the evolving techniques, the debates around drug-coated devices, the best way to manage patients afterwards, how to watch them closely, here's a final thought for you listening. With all this intricacy, how can you, as a patient, best advocate for yourself? How do you ensure you're getting the most appropriate, evidence-based care that's really tailored specifically for your situation?
That's a really important question to ponder.
Definitely something to think about. Thanks so much for joining us for this in-depth exploration.